Hello everybody, my name is Laurna Bullock and today I'm going to talk you through the presentation titled Patient and Clinician Perspectives of a New Osteoporosis Shared Decision-Making Intervention that was tested in UK Fracture Liaison Services, and this is as part of the iFraP study. I've listed here the co-authors of this abstract and presentation, and I've also included in the bottom right my contact details in case you have any questions or queries after the presentation. Shared decision-making is a collaborative process in which healthcare professionals work together with a person to reach a decision about care. It involves choosing tests and treatments based on both evidence and the person's individual preferences, beliefs and values. It makes sure that a person understands risks, benefits and possible consequences of different options through discussion and information sharing. Shared decision-making sits at the centre of many national and international policy developments, and this is reflected in the NICE Shared Decision-Making Guidance that was published in 2021. As part of this guidance, NICE recommends the use of good quality decision aids as part of a toolkit alongside other skills and interventions in order to support shared decision-making. Typically, decision aids provide evidence-based information about a health condition, the options, for example, treatment or test options, associated benefits, harms, probability, and scientific uncertainties. A decision aid should supplement rather than place a person-centered discussion about options. Often, to communicate the associated benefits, harms, and probabilities in an understandable way, decision aids often use simple frequencies, for example icon arrays or Kate's plots that show a visual representation as shown on this slide. Improving shared decision making in osteoporosis may be particularly important as people with osteoporosis report unmet needs for understandable, accessible and individualised information, with a national survey of people with osteoporosis identifying improved access to information from healthcare professionals as the most important area for research in osteoporosis. Accurate and understandable patient information is essential to facilitate shared decision-making. However, commonly accessed patient information resources about osteoporosis have highly variable quality, score poorly on readability assessments, and contain inconsistencies and inaccuracies. As previously mentioned, decision aids may be helpful as a resource to support discussions about options and to facilitate shared decision making. We recently conducted a systematic review of existing decision aids for informing patient decisions about osteoporosis treatment and found that many failed to meet international quality standards and patient needs. Based on the evidence just outlined, the Improving Uptake of Fracture Prevention Drug Treatments, the iFraP study, developed a prototype theoretically informed complex intervention to support patient and clinician shared decision-making about osteoporosis medicines. The intervention includes three components. So firstly, a decision aid that aims to support clinical decision-making and patient-clinician communication about the patient's diagnosis, treatment options, and lifestyle advice for bone health, for example, smoking and physical activity. And the decision aid includes a variety of text, images, and animations. The second component is a face-to-face and e-learning training programme targeted towards the clinicians to support their learning about shared decision-making, risk communication, and health literacy techniques that they can use during their consultations. The training programme also provided opportunities to learn about and practice using the decision aid. Finally, we also developed paper and online information resources, including a personalised printout from the decision aid that can be provided to the patient during or after their consultation, and this was to summarise the discussions had in the appointment. This same printout could also be provided to the patient's general practitioner to promote consistency of information. The proposed iFraP intervention was primarily designed for Fracture Liaison Services, so often shortened to FLSs, which are typically nurse-led services that enact secondary fracture prevention by proactively identifying patients in secondary and/or primary care who've suffered a fragility fracture, defined as a fracture resulting from low or no trauma, and they assess the patient's bone health, their risk of falls and future fracture, and provide treatment recommendations to the patient. We followed the Medical Research Council guidance on complex intervention development and the three-step implementation of change model to develop our iFraP intervention. And here on this slide, I've very briefly provided an overview of what the development work involved. So first, in the top left-hand corner, we can see that we synthesised existing evidence, guidance and patient resources, and that fed into our primary data collection that included qualitative research, so focus groups and interviews with patients, FLS clinicians and GPs. We also completed 2 surveys, so a Delphi survey with patients and clinicians to identify tasks for a model FLS consultation, and also a national survey of Fracture Liaison Services to understand usual care and current practices across the UK. Further information about this work can be found by following the QR codes on the slide. Throughout the entirety of the development work, we met frequently with our PPIE members and also our group of key stakeholders that helped to inform the development of the intervention. Following the developed prototype of the iFraP intervention, this was tested in practice, which will be the focus of the remainder of this presentation. So the aim of the in-practice testing study was to explore perceived acceptability by those using the iFraP intervention, to identify barriers to and facilitators of implementation in practice, and identify necessary changes to the prototype iFraP intervention before rolling out into further wide-scale testing. So now I will give an overview of the methods that we used for our in-practice testing study. So FLS clinicians based at one UK hospital site were recruited to take part in the in-practice testing study, and all of those clinicians received the iFraP training package. Patients with a recent fragility fracture who were referred to the FLS for a consultation as part of usual care were invited to receive the iFraP intervention. The FLS clinicians delivered the iFraP intervention to consenting patients in 3 cycles. Consultations in which the iFraP intervention was delivered were observed and audio recorded by the researcher. By splitting testing into blocks or cycles, allowed collected data to be reviewed with the opportunity to provide feedback to the clinician before continuing on the next cycle of testing. Immediately following their consultation, patients completed think aloud interviews, with the research reflecting on aspects of the observation that were seen particularly important or noteworthy. At the end of each cycle, the clinicians that had delivered the intervention also took part in interviews. Audio clips of their own consultations were played during the interview to stimulate clinician recall. Patient and clinician interviews were analysed using an inductive framework analysis with multidisciplinary team members. So now I will give a brief overview of the participants, but also the findings of the in-practice testing. So as you can see here, 4 clinicians delivered 10 iFraP consultations and completed 7 interviews across the 3 cycles of testing. All 10 patients that received the iFraP intervention completed an interview after their consultation. Overall, patients and clinicians found use of the decision aid acceptable in Fracture Liaison Service consultations, with clinicians enjoying using the decision aid, and as you can see here in the right quote, the patients described it as fantastic. FLS clinicians suggested that they had wished to continue using iFraP, so the decision aid, in their usual practice, and thought that, as outlined in this quote, it would be invaluable for other services to use. And in this quote we can see one of the clinicians reflected on the iFraP training package and thought of it as an integral component of the intervention. And this really highlights the benefits of multi-component interventions to support shared decision making. Patients and clinicians perceived iFraP to achieve its aim to increase patient involvement in the consultation and provide accessible and understandable information to support shared decision making, with patients describing the decision aid and information provided by the clinician as very easy to understand, as you can see in that top right quote. Clinicians also thought that the iFraP intervention, by improving shared decision making, had potential to meet their professional and service goal to increase patient commitment to osteoporosis medicines. An important part of the iFraP in-practice testing was also to identify barriers to implementation and necessary changes to the prototype iFraP intervention. Barriers included clinicians' perception that the decision aid would increase the length of the time-limited consultation, and given service pressures, this was a key concern of our clinicians. They also mentioned patient factors such as impairments, so visual, hearing, cognitive impairments that may mean that a patient can't engage with the decision aid, and also the patient's ability to read English. Clinicians also mentioned consultation characteristics that might act as a barrier. Some clinicians felt unsure of how the decision aid could be used as part of telephone consultations, as the decision aid is inherently quite visual and used on the computer. The participants also recommended changes to the intervention, such as minor updates to visuals in the decision aid, as well as updates to the structure of the information included to better flow with their existing Fracture Liaison Service consultation. Clinicians also recommended that the training package had allocated time to practice using the decision aid, or increase that time for them to become familiar and also practice using it in their consultations. Clinicians also recommended that the intervention includes more materials to guide them using the decision aid in varied consultation types. For example, more support on how to deliver the decision aid as part of a telephone consultation, or for patients that are not recommended a medicine as part of the consultation. In conclusion, the iFraP intervention was viewed by patients and clinicians as acceptable, with the potential to achieve its aim to support patient involvement in the consultation and facilitate shared decision-making about osteoporosis medicines. The iFraP training package was seen as being an integral component of this intervention to support shared decision-making, reiterating that the use of decision aids should be as part of a toolkit as recommended by NICE, and that a use of a decision aid in isolation doesn't necessarily always result in shared decision making in a consultation. The iFraP intervention is currently being updated in line with findings in collaboration with stakeholders and our PPIE group, and this is in preparation for the iFraP randomised controlled trial that's starting later this year. On this slide, I've included some QR codes to access some of our published papers, and also the iFraP study website for more information. So thank you for listening. If you have any questions or comments on this presentation, then please do feel free to contact me on the contact details on this slide. And just a big thank you for the rest of the iFraP team that have been involved in this project.